We're here with Dr. Ken Donaldson, Medical Director for the NHS, Dumfries and Galloway in Scotland. Ken has been kind enough to share some of his experiences of being a medical director that includes an acute care hospital in Dumfries. Ken, why do you think hospitals are equated with a bad death?
Going back maybe 20, 30 years, to come into hospital and spend a week, 2 weeks was fairly normal. These days, the wish to have just a matter of days and then either back home or out to a setting in the community. But our demography has changed and patients have multiple comorbidities. They may have heart failure, kidney failure, other organ failures, and when they present, they're complex. But the way the hospital is set to work, we're still looking for a diagnosis, something we can treat, something we can make people better. But often that's really not possible. But these patients then end up staying in the hospital for a period of time, perhaps having many tests and different treatments, but actually they are reaching the end of their life.
How has this continued to change in the last decade or so?
We have an aging population of people who have multiple comorbidities. And that makes their presentation in an acute hospital more complex than it was, say, 15, 20 years ago. I can remember myself when I was doing medical receiving, the patients who came in when I was a junior doctor had a heart attack or a stroke or an exacerbation of their COPD. And I think this has changed over the last 15, 20 years for many factors. There's a lot of good secondary prevention. There's preventing death at an earlier age, so people are living longer, but they carry this burden of comorbidity. Along with the change in demography, we've seen a change in our workforce, and that we are struggling to, well, for a while, and still is, doctors, but also nurses and AHPs and pharmacists. So there's a difficulty in recruiting all these healthcare professionals, and that puts an extra strain on our staff in that they perhaps don't have the time to really get into some of the detail of patients. And with numbers increasing through the front door, that can lead to just trying to process patients quite quickly to get to the problem, move them on, and we're not really dealing with the actual heart of the matter, which might be somebody who's reaching the end of their life.
I'm wondering if you can speak a bit about what specific characteristics might make a death bad or good from the patient and family member perspective in the hospital.
Often I've seen many families, in particular when I'm speaking to them in the bereavement phase, and the anger is that we didn't know mum or dad was dying until the day before when they told us that he died. But we look back and we realise she'd been dying for weeks, but we didn't have time to say our goodbye and process that. And I think that's that important, that palliative approach, which you can still be doing the odd test and be thinking about treatment. But if you're thinking, well, perhaps the patient is reaching the end of their life, you can have that honest conversation with both patient and family, and that can relieve that trauma.
Clinicians can have a hard time because individualizing care can be challenging. So I'm curious from your perspective for you to talk about some of those differences and how clinicians and the system negotiate that.
Everybody has a different take on what they perhaps see their own death being like, and I think that can often change through time as well. That people may say, "Oh, this is I want to die at home and I want this," and then but actually as it comes nearer and they perhaps there's a bit of fear about being at home, then it may change. The important thing for our clinical colleagues is that recognising that individualism and treating every patient as that single person, what it is what matters to them. And the difficult bit, and I feel this myself, having done it for many years, is getting beyond what I think is the right thing. And it's what they believe is the right thing. And ensuring that we share a bit of each other so that I know what it is matters to them and they perhaps understand what my specialist experience in this area is, so we can do the right thing for each individual patient and their loved ones.